Hello, my name is Hatim Yagub. I'm a MSc student in health economics. I'll be presenting today about the merits of social health funding for funding healthcare compared to tax-based funding. So I'll be talking about different modes of health financing. Predominantly, I will be defining what is tax-based financing and what is social insurance financing. I'll be talking about similarities and differences between the two systems. I will talk about how social health finance can best tax-based financing. I will also mention some evidence-based data in favor of either of them. I will not be discussing private financing, which is private insurance and out-of-pocket payments, and I won't be talking about doctor-patient agency and moral hazards. WHO defines health as a state of complete physical, mental, and social well-being, and not just merely the absence of disease. Um, Health financing could be done in two ways. It could be either private financing, which I'm not going to talk about, and public financing. Public financing has two major models: the tax-based system, or also known as the beverage system, and the social health insurance system, which is also known as the Bismarck model. Um, Sir William Beveridge laid down the first outlines of the new health system in the UK, and he is the father and the founder of the Beveridge tax-based system. He sees the health as a right and not a privilege. To every citizen is entitled for it. Health financing is usually by health financing is through the government revenues and taxation mostly. In this model, the health system is owned and run and operated publicly by the government, and its aim is to provide equitable and accessible healthcare to everybody. It's typically adopted in the UK NHS system, the Irish HSE system, the Sweden, Australia, and Canadian health systems as well, among many others. The social security system or the social insurance funding, known also as the Bismarck model, first founded by Otto von Bismarck in Germany when he constituted the new health insurance program in the 1880s. At that time, so it's essentially funded through payroll contributions from employees and employers as well, and that funding goes into a sickness funds to meet the health needs of the workers. Providers and payers are usually private, but there's some governmental regulation for the whole process. Um, Mr. Bismarck sees this as a right associated with the labor status and was mostly aimed at keeping workers very healthy to ensure productivity and minimize time off work. Um, the two systems can differ into the ways the funds are raised, as we have seen in the delivery system and in the health outcomes. So first, I'm talking about the tax-based system. To have a well-functioning and good flow of funds, you need to have a well-designed and efficient taxation system to minimize tax evasion. And that's what we see in the NHS, for example. Um, in the privileged countries generally, governments tend to try and spend lesser amount of money in health compared to the other social security system countries. The funds themselves might not even be sufficient to provide high quality or a good quality care, and it can lead to substandard care and dissatisfaction among the public people. Governments might respond to that by asking for more taxes, which can cause more dissatisfaction. In contrast, the social insurance funding model, people are usually found to be more willing to pay their contributions towards the sickness funds compared to paying taxes. Um, this might have something to do with the person knowing that this money is going towards my health and my colleagues' health, compared to the taxes where you don't actually know where it's going to. People are also more likely to show solidarity to their colleagues at work in this system than general public, which is the case in the tax-based system. There are some issues with delivery in the tax-based system. It has longly and all the time been criticized for its long waiting times and the queues for services, and this is typically seen in the NHS system in the UK. This can result in more dissatisfaction, and there's also a tendency for higher out-of-pocket spending as patients might try to bypass those long queues to go privately or to buy insurance plans privately as well, or to even travel abroad and get the health service delivered abroad. Politics can influence and actually can manipulate the tax-based system funding. The government has full control, almost full control of the amount of funds that goes into the health system. And they all governments have their all competing demands for funding, and health system might not always be prioritized. In Finland, for example, when it went through the fiscal time in the 1990s, health was as expected. Health was expectedly slashed, and a lot of money went out of the health budget. But we see that later on in the 1990s, when the economy recovered, that money didn't go back into the health budget easily. It took a few years for that to happen. So this has led to the concept of earmarking, and by earmarking we mean that a certain amount of money being coming from tax or from revenues that has been allocated to a certain service, say for example health, should only be used for that purpose and not for anything else. And that's called hypothecated taxes or earmarking of the funds. Um, there's a lot of advantages and some disadvantages as well. Mostly, it increased the efficiency of the public expenditure by linking taxes to benefits received, and people have more trust in the system. And this can also lead to reduce in the resistance to pay taxes and tax evasions. Other issues with the tax-based system, it tends to be less competitive because it's a monopoly. So there's no incentive to increase quality and volume. It is questionably applicable to low-income countries where salaries are low, so taxes raised from those salaries are very low as well. So there should be an alternative way of funding the health system. There's generally a lower patient satisfaction in tax-based system due to long queues and delays in services and many other things, and most people regard it as not a good value for money. It can be difficult and might be a longer process to introduce new technologies such as new medicines or new techniques or new procedures or new devices, because it costs a lot of money, and then funds has to be found to meet those demands. And this is certainly taking longer time in the tax-based system compared to the social insurance system, which might lead to all other sorts of disadvantages, such as out-of-pocket payments, people going abroad, people going to different different service providers to avail for those services. So can the social insurance funding system be a better alternative to tax-based system, which is the beverage system? Now, the social health insurance system has a lot of advantages in it. It's a welfare system with more money in the health. Earmarking can easily be applied. There's generally less out-of-pocket payments. There's a less risk of catastrophic spending. It is less affected by politicians and their demands and by financial downturns in the countries. But there are certain concerns about this system as well. Adverse selection is one of the major criticisms. Adverse selection means sicker people tend to purchase health insurance plans while healthier people tend not to, and that can cause a significant disadvantage for the insurers, and they might not be able to meet the demand. Risk selection, on the other side, is a behavior of the companies themselves when they try to avoid adverse selection by actually enrolling more healthy people in their plans and trying to avoid enrolling sicker and people who are more likely to utilize healthcare. There's generally high cost in it, and some part of the communities might not be covered. It can also lead to high unemployment rates. So there are certain procedures and certain technique that has been implemented in trying to minimize those issues that are embedded and inbuilt into the social security system. A lot of the insurers have now been demanded to apply minimum standards to all the plans that they provide. So this ensures that a basic level of care, or if you might say a safety network, is available for everybody. And people then might actually buy higher insurance premiums if they want to have a better service, and they have to pay more money. Open enrollment is very central, so nobody should be rejected, and this is a way to avoid risk selection. So the insurers shouldn't really reject any customer regardless of his likelihood of being sick or utilizing the healthcare. Community rating should be used instead of risk rating, and that means all the employers in the certain firm or in the company pay the same amount of contribution to the sickness fund regardless of their likelihood of utilizing healthcare, and this is called risk pooling. Compulsory participation, essentially everybody should buy a health plan. This might not always be possible, has its challenges. More competition usually manifests in this system and makes services more affordable and helps to actually achieve universality and high quality of service. There's also cost containment protocols to try and minimize the cost in those in this system. Now, in the next few slides, before I finish my presentation, I'm going to talk about this landmark trial research article published in 2007 by Van der Zee and his colleagues, and it's titled "Bismarck or Beverage: A Beauty Contest Between Dinosaurs." So what they did in this research, they divided the Western European countries into two groups: group that adopt the social health system, and the other group that adopt an NHS beverage-like system. And they look at three indicators: health outcomes, cost, and patient satisfaction. Overall death rates were found to be non-different, to be convergent. They tend to converge, and that's overall mortality. If we focus at infant mortality rate, you can see it continues to improve in the social system until it actually converged with the tax-based system, and with no significant difference in infant mortality in both systems since the 1985. So equal percentages. Total expenditure of on healthcare per capita tend to be higher in the social insurance system compared to the NHS-like tax-based system, and total expenditure as a percentage of the GDP also tend to be higher in that system. Now, patient satisfaction tend to be higher in the patient with the social security system, with this graph showing about 50% of the patient in the tax-based NHS system actually report being fairly or highly satisfied with the service, compared to almost 70% being fairly or highly satisfied in the social security system. So what are the conclusions of this research article? Social health funding systems perform slightly better in the overall mortality rates and life expectancy. For infant mortality, the rates coverage between the two types of the systems are the same, so that social systems actually perform better in mortality. Infant mortality is not that different. Social systems tend to be more expensive, while the tax-based system tend to have more cost containment measures. Countries with the social health funding systems usually patient shows more satisfaction with the health system compared to the other countries. So what are the take-home messages from this presentation? I think the most important thing is there's no one size fits all. Each one of the systems has its own advantages and disadvantages. A lot of countries actually try to make use of both systems by marrying them, mix them into a mixed model. So you can either have a beverage model with a Bismarck flavor, or a Bismarck model with a beverage flavor, and then come up with a good mixture.